couple of you have mentioned we need to get the patient engaged, and we need to think about the patient's responsibility when it comes to care. Matt, in a Medicaid population, I mean, do you see possibilities there? People often think that some of these things that may work in employer populations are a little bit more difficult.
Yeah, I think that the challenge is that, what's being developed now and what they're calling the value-based insurance design, and Austin talked a little bit about this. If you want to go off the preferred list for whatever reason, then you pay a little bit more or something. Doesn't work in Medicaid because whether you do, whether you don't, the patient cost is effectively zero. But that just means you need to be more creative. You need to figure out, there's probably going to have to be more carrots than sticks. There are more. You got to go to the patient to figure out what it is that actually is going to motivate them. Is it purely a convenience issue? And then okay, well, let's talk about: can we set up minute clinics and get you there? Is childcare your biggest issue? Okay, well, let's figure out if you can do, if you go to the highest quality, lowest price provider, maybe we can kick in some childcare subsidy or something like that. You can be creative, and I think that's it's complicated, but it's possible and it's important. And I think at the core of it, it's similar to what's happening, and we've talked about this a little bit, and hopefully we can talk a little bit more about the way that insurance in general is changing, away from a strictly medical model and more towards embracing the social determinants of health. And to do so, everybody has to think very differently. Covering social services and supports comes as a bit of a challenge for insurance companies and maybe even for physicians. Similarly, trying to figure out what do you need to engage the patient is going to require some different thinking. It's possible and it's necessary.
Mm-hmm. So maybe, if I could just follow up on that, I mean, in state budgets, there's a lot of different line items for social service providers,
right.
And it's not always clear that they integrate well with
right.
the big line item in terms of Medicaid. Are you seeing any broader discussions, any change in that direction where the Medicaid program and other social service providers at the state government level are talking to each other and realizing how
Sure.
much their work depends on each other?
Yes. Now, traditionally what's happened is that, Medicaid has a lot of visibility because it's the biggest line item in any state budget, pretty much. And because of the way it's financed, it's an open-ended entitlement. Lots of other of those line items or silos within state budget: education, public health, corrections, mental health, et cetera, tend to look to Medicaid to say, oh, hey, I bet you can solve my budget problem. If you just did this, wouldn't that be great for the patient or the system? But what we're seeing now is, and that may be true, but the challenge is you have to have what I call kind of enlightened governance. You have to have somebody who, whether it's the governor or the legislature, the appropriations or finance committees, or whether it's a budget officer, somebody who is looking at all those line items and saying, I get it, this makes sense. Because if you don't, then what happens when Medicaid starts to pay for traditional public health functions? What happens when Medicaid tries to get much more engaged in school-based health functions? What happens when Medicaid tries to get more engaged in serving institutionalized correctional facility populations? The immediate reaction in most places is Medicaid's growing out of control, time to clamp down on it.
And none of these other sectors want their budgets reduced either.
Right. So as long as you've got somebody who sort of says, I get it. We're going to spend more on Medicaid because it's going to reduce the state's exposure, or it's going to do these things. I get it. I'm not going to freak out. Mm-hmm. Then we're in good shape.
Well, part of that,
I think patient engagement is one of those issues where I think people have excessively high expectations of the impact that it's going to have. But I do think that there are opportunity areas where, I was a very engaged pregnant mother, and had 2, good normal deliveries and so forth. I don't know what happened to that. That sort of went backwards. But end-of-life care, the conversation project that Ellen Goodman is leading, I think that's great, although it needs to be paired with a delivery system that is actually committed to honoring those end-of-life wishes, which is really, not happening in a lot of these situations. So I think that patient engagement is a necessary ingredient for making things happen, but the delivery system and the payment system have to support the patient engagement.
Well, I think Matt had a very important point about thinking about what kinds of incentives can you build creatively into a benefits design that are based on what people really value. So that can be money, but it can also be childcare or transportation or the other kinds of things. But our healthcare system has no tradition at all of caring at all about what patients think. And we tend to try to define quality in a very scientific way according to what's high quality for the most people, but what one person thinks is good for them may be different from another person. And I think we need to start to understand those nuances. Again, other industries, they know those things. I mean, they know that sometimes the reason you want to buy a particular car is because you like the color. And that matters. That matters a lot to auto manufacturers, just as much as it matters to them that the engine actually functions properly. So I think we are going to have to completely change how we think about the perspective of the patient, how we incorporate that into the business of healthcare and into the financing system.
So imagine redesigning a system with a patient in mind. What a
Well, it's
novel
actually,
idea.
it's kind of marketing. It's kind of marketing and
It
market
is.
segmentation and really understanding your customer.
Yeah. So Austin, I wanted to ask you, with all these changes that are going on, and we've heard and discussed a number of them, and many of them coming out of CMMI, the Innovation Center. You're a researcher, as am I. Are we taking time to study these appropriately and ultimately learn the lessons? We've got so much going on, or are we moving a little too fast in terms of implementation without really understanding kind of what works and what doesn't?
Well, I don't know if we're moving too fast, but I do know we're not moving too slow. So, my colleagues around the country, and you know them as well, are trying to keep up with the research. It always seems to come out too late, but that's just kind of the way research is. But we do need to keep doing the research. We need the research to be funded. We need the data to be available and accessible. And it's really the only way we're going to know what the effects of these programs are is to have independent researchers do them. I don't put a lot of weight into official CMS press releases about what the results are. Usually they're comparing results to not the comparison group of facilities that we as researchers would choose or think appropriate. A lot of these programs are systems are self-selecting into them. You self-select to be an ACO, and until the most recent announcement, bundled payments were also voluntary. I believe that's right. So you have a lot of concern about what the effects on biasing the results are.